Imagine a mother just gave birth safely, but within 15 minutes, she starts bleeding heavily. This is not just bleeding, it's a medical emergency that claims thousands of lives every year. Today, on Medical Study 19, let's talk about one of the most important and life threatening conditions in obstetrics, postpartum hemorrhage or PPH. Now, PPH is defined as the loss of blood more than 500 ml after vaginal delivery or more than 1000 ml after cesarean delivery is known as postpartum hemorrhage or excessive PVB that causes hematocrit drop more than 10% that require immediate transfusion is also the definition of PPH. Now, postpartum hemorrhage is classified into two types: primary postpartum hemorrhage and secondary postpartum hemorrhage. If the bleeding within the first 24 hours after delivery, it is called primary postpartum hemorrhage, and if bleeding occurs happens after 24 hours till 12th week, it is called secondary postpartum hemorrhage. In visual blood loss estimation often underestimates more accurate method, and blood collection drapes weighing swabs are the methods for the calculation of blood amount that are lost during after the delivery of baby. Now estimated blood pad, one pad equal to 120 cc, tampon equal to 50 cc, gauze is equal to 30 cc. A small abdominal pack is about equal to 250 cc, and large abdominal pack is about 450 cc. Now hemorrhagic shock. Classification of hemorrhagic shock in relation to clinical criteria and percentage of total blood volume lost. Total blood volume at term is approximately 100 ml per kg. Blood loss more than 40% of total blood volume considered as a life-threatening condition. Now, class, percent of blood loss, blood pressure, and sign and symptoms. In class compensated shock, the percent of blood loss is about 10 to 15%, and there will be the normal BP. The sign and symptoms will be palpitation, dizziness, and tachycardia. In mild class, the percentage of blood loss will be 15 to 30%, and there will be the slight fall in blood pressure. Sign and symptom will be palpitation, thirst, tachycardia, weakness, and sweating. In moderate class, the percentage of blood loss is about 30 to 35, and blood pressure will be 70 to 80 mm of Hg, and sign and symptoms will be restlessness, pallor, oliguria. In severe class, percentage of blood loss will be 35 to 40 percentage, and blood pressure will be ranges from 50 to 70. The sign and symptoms will be pallor, cyanosis, and collapse. And the highest class, that is also known as profound, the percentage of blood loss will be 40 to 50%, and the blood pressure will be 50 mm of Hg, and the patient will collapse, air hunger, and aneurysm will be seen. What are the actual causes of PPH? The causes of PPH are remembered by the four T's. One T means ton, another T means tissue, another T trauma, and another T thrombin. Ton means uterine atonicity. Due to the atonicity of the uterus, this is the most common cause which is responsible for death of a person. Tissue, retained placental tissue. Trauma, which includes due to genital tract, tearing of genital tract, uterine rupture, and thrombin means abnormality of coagulation. It includes coagulation disorder. Ton, uterine atonicity. It is about 75 to 90% of cases of PPS are due to uterine atonicity. Uterine hyperdistension, it is mainly due to the macrosomic baby, means if the large size of the baby is there, then it will cause atonic uterus. Or multiple pregnancy, if the mother is having more than one child earlier in the previous pregnancies and also having twins pregnancies, it will also be the responsible for uterine atonicity. Previous PPH, if there is a history of previous postpartum hemorrhage, it will also be the one of the cause. High parity, precipitate or prolonged labor are also the factors responsible for atonicity of uterus. Chorioamnionitis, if there is a more fluid. Obesity, if the basal metabolic index is more than 35 and age of the mother is about 40 years and she is an anemic, then it will also be the cause for atonic uterus. Tissue means retained placenta. Trauma, it is about 5 to 10% of cases found. And operative vaginal delivery by vacuum or forceps. Caesarean section, mediolateral episiotomy, poor skill in guarding the perineum are also the factor responsible for causing the postpartum hemorrhage. Thrombin means pyrexia in labor, placental abruption, pre-existing bleeding disorder like hemophilia, patient on anticoagulant came under thrombin. Now, how to prevent PPH? Identify the risk factor that may present antenatally or intrapartum will help us to plan the delivery. However, most cases of postpartum hemorrhage have no identifiable risk factor. Active management of third stage of labor lowers maternal blood loss and reduces the risk of postpartum hemorrhage. Now, active management of third stage undergoes use of uterotonic drugs, uterine massage, control of cord traction for delivery of placenta, and prophylactic oxytocin should be given routinely to all women as it reduces the risk of postpartum hemorrhage by 60%. And syntrometrin, it is the drug combination of oxytocin plus ergometrin, may be used in the absence of hypertension. For cases with no risk factor and delivering vaginally, give intramuscular oxytocin 5 international unit or 10 IU international unit. For cases of cesarean section, give intravenous oxytocin 5 unit by slow infusion. It should be given slowly. Carboporous, also known as hemabate, it is the it is the best uterine tonic drug and maximum of 8 doses can be given. It is also known as PGF2A, best drug for PPH is carboporous. Mesoporous of 600 mcg orally may be used in home birth setting but not effective as oxytocin. All women with previous caesarean section must be checked for placental site and any presence of placenta agrita. Patient with placenta agrita that diagnosed antenatally should be managed by consultant obstetric and gynecologist, a tertiary center. Reduce the blood loss by leaving the placenta in the uterus after delivery of the baby by fundal classical uterine incision, followed by hysterectomy or the treatment with methotrexate. Now, role of Prophylactic interventional radiology in the case of antenatally diagnosed placenta agrita, like balloon occlusion, embolization of pelvic arteries, and studies done so the procedure have value in control of primary postpartum hemorrhage and secondary postpartum hemorrhage. Now, management, communication, resuscitation, monitoring and investigation, arrest the bleeding. Communication, alert all relevant professionals. For major postpartum hemorrhage, activate red alert, call experienced midwife, call specialist, alert consultant, call anesthetist, a specialist, alert consultant, clinical hematologist on call, alert blood bank, call PPK for delivery of specimens or blood, alert one member of team to record the events, fluids, drugs, and vital signs. Communicate with the patient and the partner with clear information of what happening. It is very important. And to resuscitation. In resuscitation, we look for ABC. The measurement for resuscitation depend on condition and degree of shock. Assess first of all airway and then breathing. Give oxygen 10 to 15 liter per minute through face masks, regardless the maternal O2. If airway is compromised due to impaired conscious level, need to intubate with anesthetic assistance. Now, evaluation of C, circulation. Two large bore branula of 15 to 16 gauge, either 14 to 16 gauge. Take blood for FBC, coagulation profile, BUSE, CR and LFT, fibrinogen, GXM 4 units. Position should be flat and lateral tilt. Keep patient warm. Give crystalloid infusion, also known as Hotman, in major PPH. Add transfuse blood as soon as possible. Until blood is available, total volume of 3.5 liter, crystalloid infuse up to 2 liter of warmed crystalloid called Hartmann solution and or colloid of about 1 to 2 liter as rapidly as required if blood is still not available. May require DIVC regime. FFP 4 units for every 4 units of packed cell. Platelet concentration, if platelet less than 50 into 10 to the power 9 per liter, and crypto precipitate if fibrinogen less than 1 gram per liter. Aim to restore the both blood volume and oxygen carrying capacity. Volume replacement must be undertaken on the basis that blood loss is often grossly underestimated. The therapeutic goal of management of massive blood loss is to maintain hemoglobin more than 8 gram per del, platelet count more than 75 into 10 to the power 9 per liter, prothrombin time more than 1.5 into mean control, and APTT should be less than 1.5 per mean control, and fibrinogen should be more than 1 gram per liter. This is according to the 2006 guideline of British Committee for Standard in Hematology. The values are taken from there. Role of recombinant factor 7th therapy. Used in treatment of hemophilia, used in reducing the bleeding in postpartum hemorrhage, in life-threatening postpartum hemorrhage, and in consultation with a hematologist. Recombinant factor 7A is used as an adjuvant therapy and dose of 90 mcg per kg is given. Role of anti-fibrinolytic drugs. There is a role of management of obstetric hemorrhage. Now 3. Monitoring and investigation. Take blood as mentioned. Monitor blood pressure, pulse rate every 15 minutes is a minor PPH. Continuous blood pressure, pulse rate and respiratory rate in a major postpartum hemorrhage using oximeter, cardiac monitoring, and automated BP recording. Put Foley's catheter to monitor urine output. In certain cases, consider arterial line monitoring by experienced staff, transfer to ICU or SDW once bleeding is controlled, documentation of fluid balance, blood and blood products are and procedure, central line by senior skilled anesthetist may be required, and recommendation for central line and arterial line for pressure monitoring when CVS is compromised by hemorrhage or heart disease. And now anesthetic management. Anesthetist needs to assess woman quickly to initiate or continue resuscitation to restore intravascular volume and provide adequate anesthesia. Presence of cardiovascular instability is a relative contraindication to regional anesthesia as it may cause arrhythmias. Blockage of sympathetic system can potentially lead to worsening hypotension due to hemorrhage, so it should be prevented. General anesthesia is more appropriate when there is a continuing bleeding and the cardiovascular instability, and ventilator with a high oxygen concentration may be needed. Now, for arrest the bleeding. Depends on the cause of massive bleeding, common cause uterine atonicity. For that, mechanical, pharmacological, and surgical management is the best part for treatment. In mechanical management, by bimanual uterine compression to stimulate uterus to contract. You can also give uterine packing, uterine massage, Buckley balloon catheter or condom catheter can be used. Erotic compressions. Also, if uh, for pharmacological management, repeat intramuscular syntocinon or syntrometrin drug in IV, intravenous pitocin 40 units in 500 ml Hartmann solution run at 125 ml per hour, and intramuscular carboprost of 0.25 mg may be repeated at interval not less than 15 minutes to a maximum of 8 doses can be given, and it is contraindicated in asthma. If the patient is suffering from asthma, it should be avoided. Intramyometrial of carboprost 0.25 to 0.5 mg and misoprostol of 1000 mcg rectally or survagimen per rectally is given. Now, this is the drugs used to manage postpartum hemorrhage. Oxytocin, or also known as pitocin, methyl ergometrin, also known as methyrgine, prostaglandin INF2 alpha, also known as prostin 15 IM or hemabetate, or also known as carboprost. Action of oxytocin: contraction of uterus, contraction of and contraction of uterus and prevents from bleeding. And methyl ergometrin will also be at same contraction of uterus and decrease the bleeding, and prostaglandin will act as contraction of uterus. What are the side effects of oxytocin? Infrequent intoxication, nausea and vomiting will be caused. In methyl methylgreen, then water hypertension will be caused, nausea and vomiting, headache, and prostaglandin will cause side effect headache, nausea, vomiting, and fever. Now, in which condition oxytocin is contraindicated? None for PPH. Methyl ergonovin or methyl ergometrin in case of hypertension and cardiac disease, it should be contraindicated, and prostaglandin should be contraindicated in case of asthma and hypersensitivity. Dose or route. Oxytocin should be given about 10 to 40 ml diluted in 0.2 mg IM every 2 to 4 hours, or 0.25 mg intramuscular or lactate ringer solution up to 5 doses can be given of 0.2 mg intravenous in intramyometrially every, or normal saline at 125 only for emergency condition, and 15 minimum up to 8 doses of intramuscular can be given of carboprost. Nursing constitution constitute to monitor, check blood pressure, constitute vaginal bleeding and uterine tone, check blood pressure before giving, and do not Give if more than 140 per 90 mmHg if the blood pressure is raised, and continue monitoring vaginal bleeding and uterine tone. And for carboprost or prostaglandin, continue to monitor vaginal bleeding and uterine tone. And surgery, if pharmacological management fail, then sutures of Billin suture, it will bring anterior wall and posterior wall together. Heman suture, balloon tamponade, various types of hydrostatic balloon catheter can be used, as I have already told. Foley catheter, Buckley balloon catheter can be used. Condom catheter, Buckley balloon catheter, you can see the picture here. The intervention described as the tamponade test, a positive test and a negative test. A positive test able to control PPH following inflation of balloon indicate the laparotomy is not required. And if there is a negative test, continued bleeding following inflation of the balloon indication to proceed to laparotomy. No evidence of how long the balloon tamponade should be left in place till it. Most cases 4 to 6 hours of tamponade is adequate to achieve hematostasis and should be removed during daytime hours with the presence of appropriate senior staff, as a further intervention may be necessary. Hemostatic breast switcher, also known as Billings switcher. You can see here. What will it do? It will bring the anterior wall and posterior wall together. And you can also practice bilateral ligation of blood vessel, both uterine and cervical artery at the level of internal OS. Heman suture, vertical compression, bilateral as I have told it, bilateral ligation of uterine arteries, bilateral ligation of internal iliac arteries, or selective arterial embolization based on the type of uh, artery involved. And hysterectomy. If you still bleed, if there is no possible otherwise, then hysterectomy. Either subtotal hysterectomy or complete hysterectomy should be done. And arrest the bleeding by, in case of retained placenta, empty bladder, attempt CCT. If fail, proceed with manual removal of placenta, MRP, either under sedation or general anesthesia. Take consent of the patient. If under sedation, give intravenous pethidine of 25 to 50 mg, stat, or intravenous midazolam of 2.5 to 5 mg, stat. Continuous SpO2 monitoring. Lithotomy position should be kept. IV ampicillin of 1 gram stat, and intravenous flagyl 500 mg stat. Fully gowned mask long sleeve glove. Introduce one hand into a vagina along the cord. One other hand grasps the fundal of uterus, and hand just now move through the cervix to the intrauterine cavity, detaching the placenta by sideways slicing movement of the fingers. By the slicing movement of the fingers, once able to detach the placenta apart from the intrauterine wall, grasp the placenta and bring out in pieces. Then recheck again inside the uterus for any remnant part of placenta that it may be retained. And management of genital tract trauma, like suture, the cervical or vaginal wall tear, may need vaginal packing, cover with broad spectrum antibiotic. Secondary PPH often associated with endometriosis. Risk factor for endometritis are prolonged labor, anemia, underlying diabetes, choroamnionitis, operative deliveries like MRP, C-section, cesarean section, or instrumental vaginal delivery, like if the use of vacuum. X, yep, investigation, yep, BC, CRP, high and low vaginal swabs, blood culture, pyrexia, and pelvic ultrasound helps in presence of POC. And treatment for antibiotic, in case of antibiotic, give ampicillin and metronidazole, uterotonic drugs, and if continuing bleeding, may need balloon tamponade or earpoke. Flowchart for management of major PPH. Major obstetric hemorrhage is blood loss more than 2000 ml, continuing major obstetric hemorrhage or clinical shock. This is a very critical condition. Call for help. Senior midwife or obstetrician and anesthetist. Alert hematologist. Alert blood transfusion laboratory and alert consultant obstetrician. And for resuscitation, I have, as I have told, ABC, airway, breathing and circulation, oxygen max of 15 liter, fluid balance, blood transfusion, and blood products should be all kept in ready. Monitoring and investigation and medical treatment by like bimanual uterine compression, empty bladder, oxytocin, ergometrin, oxytocin infusion, carboprost. These are the other medical management. And here, monitoring and investigation. What should we investigate? Theater. Is the uterus contracted? Examination under anesthesia. Has any clotting abnormality been corrected? Then uterine balloon tamponade, breast suture, consider interventional radiology. And surgery like bilateral uterine artery ligation, bilateral internal iliac ligation, hysterectomy, second consultant, uterine artery embolization, and consider monitor at ESDU or ICU. Patient should be admitted in ICU. Thank you very much. Uh, Postpartum hemorrhage, as we have already studied about this, postpartum hemorrhage is one of the leading cause of maternal death worldwide. But with prompt recognition, quick resuscitation, and proper management, the most cases can be saved. This was all about postpartum hemorrhage, its causes, symptoms, management, and prevention. I hope this video helps you in your studies and clinical understanding. If you found this useful, don't forget to like, share, and subscribe to Medical Study 19 for more detailed medical videos.